Hello friends, in the series of the next swelling, the next topic is on the thyroid. As all of you know that the enlargement of the thyroid is called as a goiter, and there are many causes for the goiter are there. It can be a non-toxic goiter, it can be a toxic goiter, and there are other types of the conditions which can lead to the enlargement of the thyroid. Now in the non-toxic variety, it can be a diffuse variety, it can be a multinodular variety, it can be solitary nodule may be there, or it may be a recurrent type of the nodule may be there. In the diffuse variety, it can be because of the physiological factors, or it may be endemic, or it may be because of the iodine deficiency. In the toxic one, it can be again a diffuse variety, and if this diffuse variety is usually called as a Graves' disease. If it is a multinodular toxic goiter is there, this is called the Plummer's disease. And then you can have a solitary toxic adenomas may be there, or it may be a recurrent toxic goiter, like after the operation there is some thyroid tissue left over, which can lead to the recurrent type of the toxic goiter. And then in the special groups, though they are not very special but definitely different from the other varieties of the goiter, it can be a autoimmune goiter, which can be a Hashimoto's disease or the de Quervain disease or the reduced thyroiditis. It may be an inflammatory variety, which is maybe a thyroid abscess, or there are a variety of the malignant tumors which can arise from the thyroid. The well differentiated tumors like the papillary and the follicular variety. Then it can be anaplastic variety, it can be medullary variety of the carcinoma, and sometimes even the lymphomas can also develop in the thyroid. And then in the multinodular goiter, again the same, the non-toxic, toxic, and autoimmune variety. In the non-toxic, it may be multinodular non-toxic, it may be a recurrent variety may be there, and as I told you that this is called as a multinodular variety. In the toxic one is called the Plummer's disease, or it can be autoimmune type of the multinodular goiter. Now, what you want to see really in a case of a goiter, there are mainly three aspects which we have to address. Is this goiter toxic or non-toxic? Is it malignant or it's a benign? And does it cause any pressure effect over the surrounding structures or not, like over the trachea or the esophagus or the recurrent laryngeal nerve? So what is the usual clinical spectrum of a thyroid swelling? The patient presents with a swelling in the neck. Many times they are asymptomatic, they just come with the swelling is there. But there can be features of the hypothyroidism or there can be features of hyperthyroidism. And then there can be the pressure symptoms may be there, as I told you, on the trachea or on the esophagus or the recurrent laryngeal nerve. Sometimes the Horner syndrome may be there. And sometimes these thyroid swelling may have the pain. There can be sudden increase in the size of the swelling may be there, which is usually because of the hemorrhage, or if there is a overall developing the malignancy over this, then there can be pain in the thyroid swelling. So if you look at the functional spectrum which is there in a thyroid swelling, the patient may have three types of the presentation. The patient may be hypothyroid, or the patient may be hyperthyroid, and a good number of the patients, they will just have the swelling and no symptoms are there, and that is called a euthyroid. Now in the hypothyroid, usually the patient will have a puffy face, he will have the cold intolerance, the skin will be dry, there will be decrease in the appetite, there will be weight gain. So weight gain is there while the appetite is decreased, while if it is a hyper one, it is the opposite way. Then there can be constipation, the patient will be depressed, feel very fatigued, and there can be in the female there will be menorrhagia may be there. While in the case of hyperthyroid variety, the patient, because there are chance of having the eye signs in this, so the patient may have the exophthalmos or the bulging eyes may be there. The patient may have heat intolerance, sweating, increased appetite, and the weight loss is there. So here it is the opposite way. The patient may have diarrhea, the palpitation, the patient will have the nervousness, muscle weakness, especially the proximal myopathy is present in these patients who has got the hyperthyroidism, and in the females there can be the oligomenorrhea may be there. And if we look at the pathological spectrum, it can be a benign disease like there may be thyroid adenoma or a follicular type of the neoplasm may be there, sometimes the Hurder cell or the thyroid cyst is there, or a thyroiditis is there, while on the other side, a malignant nodule may have a well-differentiated cancers like the papillary cancer, the follicular cancer, then there can be medullary cancer, anaplastic cancers may be there, lymphomas may be there, and sometimes you may have the secondaries from the other primary tumors. Now, when you should suspect a patient has got the malignancy in that nodule which is there, in a male patient in the extremes of the age, if the patient had a history of radiation exposure, if there is a family history is there, if the size is more than 4 centimeters, it's a hard and irregular swelling, and it's a fixed swelling, and the patient have the pressure symptoms like the patient with the recurrent laryngeal palsy may be there. Those things you must keep in mind, that maybe that this patient is having now the malignancy of the thyroid. So what investigations are to be done in the case of multinodular goiter? Basically, the first is that you have to see whether this patient is hypo or hyper or euthyroid. And then you can do the test for the thyroid dysfunction, like you can do the anti-thyroid antibodies, or you can carry out the test for suspected thyroid malignancy. Now, if you look at the thyroid function test is there, if you have to just screen the patient for any abnormality, then you should do only the TSH examination. And ultrasensitive TSH is very specific and very sensitive for the abnormality of the thyroid function. And if you have to look that what is the abnormality is there, and if you are asked that if you want to do just one test in a case of thyroid function test, do the free T4 for that patient, and that will tell you that does this patient is having the hyperthyroidism or not. Anti-TPO antibodies are usually like the patient is having the thyroiditis, that may be raised. The second investigation is the ultrasonography. Now, ultrasonography gives you that how much is the size and the site of the nodule in a case of a solitary thyroid nodule suspected. Does the patient have got the very small nodules which are not clinically palpable? Is it cystic or it is solid? There are features to suggest that it is benign or malignant. You look at the vascularity with the help of the duplex. Look for the calcifications. Look for the cervical lymph nodes, and then you can carry out from a suspicious nodule a guided FNAC. And ultimately, the ultrasonologist will give you what is called a TIRATES classification, which is there. TIRATES is just like in the case of breast, we have the BIRATES. Here is the TIRATE, where it is thyroid imaging reporting and data systems, and that can tell you that are you dealing with a case of a benign swelling which is there, or it's a malignant, or it's a suspicious swelling is there. Now, many times you find that there are nodes which can be seen on the ultrasonography in the patients who are having the malignancy. So, if you find what is the shape, whether it is oval to round, or it is there is a loss of fatty hilum is there, or there is microcalcification is there, or there is hypervascularity is there, a size more than a centimeter size, and it looks complex, and there may be cystic degeneration may be there. All these features will suggest that the lymph nodes which you are seeing on the ultrasound probably are of malignant origin. The next is the fine needle aspiration cytology and the biopsy which is done. Now, this has got the sensitivity of about 65 to 98% and the specificity of about 72 to 100%. And it is a very good investigation to differentiate between a benign and a malignant pathology, bearing few things where you are confused that what it is telling. But it had to be carried out if it is a small nodule is there, you cannot palpate, then in those cases definitely you will go for the ultrasound guided FNAB. It is always advised that you should go for the ultrasound guided FNAB rather than just the blind FNAB. So if the patient had the radiation exposure or their family history is there, or you find associated suspicious lymph nodes, you should always go for the ultrasound guided FNAB. A nodule which is located posteriorly, you are not able to feel it very nicely, or if there is a predominantly cystic component on the ultrasound, then you should always look for the solid area which is there, and you should carry out the ultrasound guided FNAC from that area. And based on this, you can divide into your nodule into the various patterns which are there. This is called a Bethesda category, and there are 6 types of the categories which are there. First is that you have done the FNAC, but you are not sure what it is. So there are few cells which are seen. Technically, it is not good slide which are made, or if there is a cystic fluid is there, then you label it as a non-diagnostic or it is unsatisfactory. Then it can be a benign variety, usually in less than 5%, or it can be ATP of undetermined significance or follicular lesion of undetermined significance. Then in those cases, you have to repeat the FNAC. The third is that there is a follicular neoplasm is there or suspicious of follicular neoplasm is there. It's about 15 to 40% cases. Then the fifth group is the suspicion for the malignancy, 60 to 75%, and malignant 97 to 99%. Means if the Bethesda category is saying it is malignant, it is likely to be that it is malignant. And the treatment for all these will be different. If it is a ATPI is there, you have to repeat the FNAC to confirm the diagnosis. If it is a follicular neoplasm it is giving, then in those cases you can go for the lobectomy, or rather the best is to go for the hemithyroidectomy for these patients. If it is suspicious one is there, then in those cases you have to go for the hemithyroidectomy or the total thyroidectomy can be done. And if it is a confirmed malignant which is there on the FNAB, then definitely you have to go for the total thyroidectomy. Now, if you find a cyst on your aspiration, then you can aspirate it at least for 3 times to before say that no, it has to be operated. The size, if it is more than 4 centimeter and if it is complex cyst is there and it is refilling again and again even after 3 times of your aspiration, then you should plan for the surgery for that particular nodule which is there. Now, in the case of the colloid nodule, you keep your patient on the follow-up, but if the patient has got any constitutional features because of that or any pressure symptoms are there, then you may have to do the surgery for that. And even for the cosmetic purpose also, you can carry out the surgery in this category. Now, what is the role of radioisotope scanning? Nowadays, there is not much role of the radioisotope scanning the preoperative period. It is mainly now for the postoperative. You have done a total thyroidectomy for a patient and you think that there may be residual tissue may be there. You carry out the radioisotope scan in the postoperative period after about 3 to 4 weeks. And if you find that there is still the thyroid tissue is there, then you do the radioablation by giving the patient the radioactive iodine. It can be done in the preoperative setting, sometimes in the toxic autonomous nodule which is there, or the patient has a lingual thyroid and you are not sure that that is only the thyroid tissue, or does the patient has got a thyroid tissue in the neck or not, or if it is ectopic thyroid is there, then also you can do the preoperative radioisotope scanning, but majority of the time it is not done nowadays. X-ray of the chest and neck is to be done for these patients, especially when you are going to operate this patient, because you want to see that is the trachea compressed or it is deviated, and accordingly you will plan your incision there, and your anesthetist will also see that in which direction he has to pass the tube and what should be the size of the tube. Then it can also show the retrosternal extension and the calcification in the neck. CT scan and MRI can be done in a patient with thyroid swelling, but usually it is not required. But if it is a big thyroid which is there and you are suspecting that it is invading the surrounding structures, there's a vascular encasement is there, or if there are nodes which are there, and if you are suspecting the patient having the retrosternal extension, then in those cases, before you plan for the surgery, you must have the CT scan or the MRI of the neck. Other biochemical tests can be carried out, like the serum calcium should be done, serum calcitonin may be carried out, or the CA may be carried out, especially if you are suspecting the malignancy. Thyroglobulin is useful for the follow-up of a case in a patient who has got a well-differentiated carcinoma. And then if you think that this is a part of the multiple endocrine neoplasia, then in those cases you can go for the urinary vinyl mandelic acid, metanephrine, and the catecholamines to rule out the other pathologies which may be there in a syndrome. So what is the management of a case of a thyroid swelling? Basically, it can be a medical treatment, or it can be the operation, or it can be a radiation treatment. Now, in the medical management, it is mainly for the symptomatic relief. It decreases the circulating thyroid hormones, and it is also used as a thyroid replacement therapy. Like in the patient where you have done the thyroidectomy, this patient will definitely require the thyroxine replacement for the rest of the life. So what are the drugs which are used as the anti-thyroid drugs? If the patient is having the hyperthyroidism is there, the main group of the drugs, the thianamides like the carbimazole is there, the methimazole is there, or you can use the propylthiouracil. So there are various drugs which can be used, and they are usually given in the varying doses. The response starts by 2 weeks, and the patient usually becomes euthyroid by 6 weeks, but this has to be continued for quite a long time, for about 18 months to 2 years. You have to continue if you want to keep the patient only on the medical treatment. But if you think that this patient will require the surgery after that, then you can carry out your surgery once the patient becomes euthyroid. But there is a very high relapse. Once you stop these drugs, again the patient comes back to the same symptoms of the hyperthyroidism. Then beta blockers are another group of the drugs which is mainly if the patient is asymptomatic, there is a very high pulse rate is there, the patient is very anxious, she is not able to sleep. In those cases, you can give the patient the beta blockers, and you can use the propranolol, you can use the metoprolol, or the atenolol can be used, and it is mainly used for before you undertake the patient for the surgery. Then Lugos iodine can be used before your surgery. Corticosteroids are sometimes used. You can use the thyroid replacement therapy, especially in the patient who is having the hypothyroidism is there. And then you can also use the NSAIDs and the steroids if there is a lot of pain which is there in the thyroid swelling. Now, what about the surgical management? Surgical management is meant for the malignancy. Definitely, you have to carry out the surgery because that is the only definitive treatment for the thyroid malignancy. If a toxic adenoma is there after you have prepared your patient, then you can operate this. If the patient is having the pressure symptoms are there, if the choroid nodule is there or a thyroid cyst is there, and for the cosmetic purpose, also you can carry out the surgical treatment, and you have to discuss it with the patient that what type of the treatment the patient requires. Does the patient wants the medical treatment or the surgical treatment or the radioiodine? But depending upon the various pros and cons, you can decide for the treatment of these patients. So what are the types of surgery which can be done? You can do a lobectomy is the minimum one which is carried out. You can do the hemithyroidectomy. Subtotal thyroidectomy was used to be a surgery in the past, but now it is not required to carry out the subtotal thyroidectomy. In fact, it is now abandoned now. But you can do the near total thyroidectomy or the total thyroidectomy. In majority of the cases, it is the total thyroidectomy which is carried out. Near total is done if you are not sure about that what is happening to the parathyroids and to the recurrent laryngeal nerve. So you want to save the parathyroids and the recurrent laryngeal nerve. In those cases, you can go for the near total thyroidectomy. But ultimate treatment for a thyroid problem which is there, especially if the multinodular goiter is there or the malignancy is there, you have to go for the total thyroidectomy. Nowadays, there are various minimal invasive techniques are also available for the thyroid swellings. You can inject the ethanol injection, you can do the laser thermal ablation, you can do the radio frequency ablation, you can do the microwave ablation, you can use the high intensity focus ultrasound for that. And now in the surgical side, the minimal invasive surgery which are there, what is called the video assisted thyroidectomy can be carried out. You can do the surgery not from the neck incision, but the incision well away, like in the chest or the axilla. Endoscopic transaxillary thyroidectomy can be done, or even it can be carried out to the vestibule of the mouth through the oral cavity. You can go and enter in the neck and carry out, and there will be no scar which will be there on the neck in the patient with thyroid swelling. Thank you very much.